Question 1. Governance review demonstrates a pattern of paraoptometric staff documenting subtle but persistent abnormalities in patient eye movements, including saccadic intrusions during fixation and inconsistent pursuit tracking, without consistently escalating these findings for further optometrist evaluation. Considering the risk assessment framework and the Certified Paraoptometric (CPO) certification scope of practice, which of the following represents the most appropriate and compliant course of action for the paraoptometric when encountering such findings? Option A. Record the eye movement findings briefly without detailed description and only mention them if the patient explicitly complains of related symptoms, otherwise proceeding with routine testing. Option B. Assume that these subtle eye movement abnormalities are common and not clinically significant, and therefore do not require specific documentation or reporting to the supervising optometrist, as they are likely within normal variation. Option C. Document the observed eye movement abnormalities thoroughly in the patient's chart, noting their characteristics and potential clinical implications as learned during CPO training, and then present these findings to the supervising optometrist for their assessment and further management decisions. Option D. Attempt to interpret the specific neurological implications of the observed eye movement abnormalities and provide a preliminary diagnosis to the patient, advising them on potential treatment options before consulting the optometrist. Correct answer is C. Document the observed eye movement abnormalities thoroughly in the patient's chart, noting their characteristics and potential clinical implications as learned during CPO training, and then present these findings to the supervising optometrist for their assessment and further management decisions. Explanation: this scenario is professionally challenging because it requires the paraoptometric to interpret complex eye movement findings and translate them into actionable clinical insights within the scope of their practice, while also recognizing when to escalate to the supervising optometrist. The risk assessment approach is crucial here to identify potential patient harm arising from misinterpretation or delayed action. The correct approach involves a thorough understanding of the clinical significance of saccadic and pursuit abnormalities, fixational instability, and vergence dysfunctions. This includes recognizing that impaired saccades can indicate neurological issues, abnormal pursuits can suggest cerebellar or brainstem dysfunction, fixational instability can impact visual acuity and reading, and vergence problems can lead to diplopia and asthenopia. The paraoptometric must then accurately document these findings, and based on established protocols and their training, determine if the findings warrant immediate reporting to the supervising optometrist for further evaluation or management. This aligns with the Certified Paraoptometric (CPO) certification's emphasis on accurate data collection and contributing to the diagnostic process under supervision, ensuring patient safety and optimal care. An incorrect approach would be to dismiss subtle abnormalities in eye movements as insignificant without further investigation or documentation. This fails to adhere to the CPO's responsibility to meticulously record all observed clinical data, as per the guidelines for patient care and record keeping. Another incorrect approach is to attempt to diagnose or prescribe treatment for the observed eye movement abnormalities without the direct supervision and authorization of the optometrist. This directly violates the scope of practice for a paraoptometric, which is to assist the optometrist, not to independently practice optometry. Furthermore, failing to document the observed eye movements and their potential implications in the patient's chart is a significant ethical and regulatory failure, hindering continuity of care and potentially exposing the practice to liability. Professionals should employ a systematic risk assessment framework when evaluating eye movement findings. This involves 1. Identifying the specific eye movement abnormality observed, e.g., hypometric saccades, jerky pursuits, significant fixation disparity. 2. Considering the potential underlying causes and clinical significance of that abnormality based on their CPO training. 3. Assessing the impact of the abnormality on the patient's visual function and comfort. 4. Consulting established protocols or the supervising optometrist for guidance on interpretation and next steps. And 5. Documenting all findings and actions meticulously. This structured approach ensures that all relevant information is captured, potential risks are identified, and appropriate actions are taken in a timely and compliant manner. Question 2. Stakeholder feedback indicates that patients often have questions about how light is processed by their eyes and brain, when a patient asks for a simplified explanation of the visual pathway, from light entering the eye to the brain interpreting the image, which of the following approaches best aligns with the Certified Paraoptometric (CPO) scope of practice and ethical patient education standards in the U.S.? Option A. Explain the journey of light from the cornea and lens to the retina, the initial signal generation by retinal cells, and the transmission of this signal through the optic nerve to the brain, mentioning the optic chiasm where some nerve fibers cross. Option B. Detail the complex neurophysiological processes within the visual cortex, including the specific roles of different cortical layers and their connections to other brain regions. Option C. State that such detailed explanations are beyond the paraoptometric's role and refer the patient directly to the optometrist for all questions regarding visual processing. Option D. Use highly technical ophthalmological terms to describe the entire visual pathway, assuming the patient has a strong medical background. Correct answer is A. Explain the journey of light from the cornea and lens to the retina, the initial signal generation by retinal cells, and the transmission of this signal through the optic nerve to the brain, mentioning the optic chiasm where some nerve fibers cross. Explanation. This scenario is professionally challenging because it requires the paraoptometric to accurately interpret and communicate complex visual pathway information to a patient, ensuring patient understanding and adherence to care plans, all while operating within the defined scope of practice for a certified paraoptometric (CPO) under U.S. regulatory frameworks. The paraoptometric must balance the need for clear patient education with the limitations of their certification and the potential for misinterpretation of intricate neurological and optical concepts. The correct approach involves the paraoptometric utilizing their CPO training to explain the basic principles of light transmission through the eye, focusing on the path from the cornea and lens to the retina, and then describing the initial processing by retinal cells before the signal travels via the optic nerve. The explanation should then touch upon the optic chiasm where partial crossing of visual information occurs, and finally, how this information reaches the visual cortex in the brain for conscious perception. This approach is correct because it aligns with the CPO scope of practice, which includes patient education on basic ocular anatomy and physiology, and the transmission of visual information. It adheres to ethical principles of informed consent and patient autonomy by providing understandable information that empowers the patient. Furthermore, it respects the regulatory boundaries by not venturing into diagnostic interpretations or treatment recommendations that fall outside the CPO's purview, thereby avoiding the unauthorized practice of optometry or medicine. An incorrect approach would be for the paraoptometric to attempt to explain the detailed neuroanatomy of the visual cortex, including specific Brodmann areas or complex synaptic pathways. This is incorrect because it exceeds the paraoptometric scope of practice and training, potentially leading to misinformation and confusion for the patient. It also risks misrepresenting diagnostic findings or implying a level of understanding that is reserved for licensed optometrists or ophthalmologists, which could violate state optometric practice acts and CPO certification guidelines. Another incorrect approach would be to dismiss the patient's question entirely, stating it is beyond their role. This is incorrect because it fails to uphold the ethical obligation to provide reasonable patient education within the scope of practice, and can lead to patient dissatisfaction and a breakdown in the therapeutic relationship. While the paraoptometric may not be able to provide a complete neurological explanation, they are expected to offer a foundational understanding relevant to the patient's visual experience. A third incorrect approach would be to use overly technical jargon without simplification, such as discussing photoreceptor transduction mechanisms in detail or the precise decussation percentages at the optic chiasm. This is incorrect because it fails to meet the fundamental requirement of clear and understandable patient communication, thereby undermining the goal of patient education and potentially leading to anxiety or misunderstanding. It demonstrates a lack of professional judgment in tailoring information to the patient's comprehension level. Professional decision-making process for similar situations involves first identifying the patient's core question and the underlying need for information. Then, the paraoptometric must assess their own knowledge base and scope of practice to determine what information can be accurately and appropriately conveyed. If the question falls within their scope, the paraoptometric should strive to explain the concept using clear, simple language, employing analogies if helpful, and focusing on the functional aspects relevant to vision. If the question delves into areas beyond their scope, the paraoptometric should politely explain their limitations and offer to relay the question to the supervising optometrist or ophthalmologist, ensuring the patient's needs are met through the appropriate professional channels. Question 3. Regulatory review indicates that a paraoptometric is performing a routine eye examination and observes a subtle but consistent esophoria at distance during ocular motility testing. The patient also reports intermittent blurry vision, particularly when reading. Which of the following represents the most appropriate action for the paraoptometric to take? Option A. Advise the patient that their blurry vision is likely due to eye strain and recommend over-the-counter reading glasses. Option B. Reassure the patient that the esophoria is minor and unlikely to be the cause of their symptoms, and proceed with the rest of the examination without further comment to the optometrist. Option C. Record only the objective findings of the esophoria and omit the patient's subjective complaint of blurry vision from the chart. Option D. Document the observed esophoria and the patient's reported symptoms accurately in the patient's chart, and inform the supervising optometrist of these findings for further evaluation. The correct answer is D. Document the observed esophoria and the patient's reported symptoms accurately in the patient's chart, and inform the supervising optometrist of these findings for further evaluation. Explanation. This scenario is professionally challenging because it requires the paraoptometric to balance the immediate need for patient comfort and clear communication with the strict regulatory requirements for documentation and scope of practice. The paraoptometric must ensure that their actions are both clinically appropriate and legally compliant, avoiding any misrepresentation or overstepping of their defined role. The correct approach involves accurately documenting the observed ocular motility findings and the patient's subjective complaints, and then clearly communicating these findings to the supervising optometrist for further evaluation and management. This adheres to the Certified Paraoptometric (CPO) scope of practice, which emphasizes observation, data collection, and assisting the optometrist, rather than independent diagnosis or treatment. Regulatory frameworks for paraoptometrics typically mandate precise and truthful record-keeping, ensuring that all patient interactions and findings are recorded for continuity of care and legal protection. Ethical guidelines also stress the importance of accurate reporting and deferring diagnostic and treatment decisions to the licensed practitioner. An incorrect approach of suggesting a specific diagnosis or treatment plan to the patient directly violates the CPO scope of practice and regulatory mandates. Paraoptometrics are not licensed to diagnose or prescribe. This action not only misleads the patient, but also creates a significant legal and ethical liability for both the paraoptometric and the supervising optometrist. Another incorrect approach of omitting the patient's subjective complaints from the documentation is a failure of accurate record keeping. All relevant patient information, including symptoms and observations, must be recorded to provide a complete picture for the optometrist and for future reference, as required by regulatory standards for medical documentation. Finally, an incorrect approach of downplaying the patient's symptoms without a clinical basis and failing to report them to the optometrist is a dereliction of duty. This could lead to delayed diagnosis and treatment, potentially harming the patient and violating ethical obligations to provide diligent care. Professionals should employ a decision-making process that prioritizes patient safety and regulatory compliance. This involves a clear understanding of their scope of practice, meticulous documentation, and open communication with the supervising optometrist. When faced with patient symptoms or unusual findings, the paraoptometric should always err on the side of caution, documenting thoroughly and seeking guidance from the optometrist. Question 4. Cost-benefit analysis shows that a comprehensive neuro-ophthalmic screening protocol, including detailed assessment of visual fields, pupillary function, and extraocular muscle movements, is more effective in identifying potential cranial nerve deficits related to vision than a limited examination. A patient presents with a complaint of intermittent blurred vision. Which of the following paraoptometric approaches best aligns with the principles of thorough neuro-ophthalmic assessment and regulatory expectations for a certified paraoptometric (CPO)? Option A. Measure intraocular pressure and perform a dilated fundus examination, assuming all other visual functions are normal. Option B. Ask the patient to describe their vision changes and rely on their description to guide further examination. Option C. Perform a complete visual acuity test. Assess pupillary reflexes, direct and consensual, test accommodation, and evaluate extraocular muscle function through all cardinal gazes. Option D. Conduct a visual acuity test and a confrontation visual field test, then document the findings. The correct answer is D. Conduct a visual acuity test and a confrontation visual field test, then document the findings. Explanation. Scenario analysis. This scenario presents a professional challenge because it requires the paraoptometric to interpret subtle neurological signs and relate them to potential cranial nerve dysfunction affecting vision. The challenge lies in accurately assessing visual fields, pupillary responses, and extraocular muscle movements, and then synthesizing this information to identify potential deficits within the visual pathways. Misinterpretation can lead to delayed diagnosis, inappropriate referrals, and ultimately, compromised patient care. The paraoptometric must exercise careful judgment to distinguish normal variations from pathological findings, ensuring that all observations are documented accurately and communicated effectively to the supervising optometrist or ophthalmologist. Correct approach analysis. The correct approach involves a systematic and thorough examination of the cranial nerves directly involved in vision and eye movement. This includes assessing visual acuity, visual fields, confrontation or formal parametry if indicated, pupillary light reflexes, direct and consensual, accommodation and extraocular muscle function, gaze testing. By meticulously documenting findings for each of these components, the paraoptometric builds a comprehensive picture of the visual system's integrity. This systematic approach aligns with the ethical obligation to provide competent patient care and the regulatory requirement to perform duties within the scope of practice as defined by the Certified Paraoptometric (CPO) certification guidelines, which emphasize accurate data collection for diagnostic purposes. Incorrect approaches analysis. Focusing solely on visual acuity without assessing pupillary responses or extraocular movements represents a significant failure. This approach neglects crucial components of the visual pathway and cranial nerve function, potentially missing signs of neurological compromise. It violates the principle of comprehensive patient assessment and the CPO's responsibility to gather all relevant clinical data. Performing only a confrontation visual field test and neglecting pupillary reflexes and extraocular muscle function is also an incomplete approach. While a visual field test is important, it does not provide information about the integrity of the optic nerve's response to light or the muscles controlling eye movement, both of which are critical for diagnosing neuro-ophthalmic conditions. This selective testing can lead to an incomplete diagnostic picture. Relying solely on patient self-reporting of symptoms without objective testing of visual fields, pupillary function, and extraocular movements is a critical ethical and regulatory failure. Patient perception can be subjective and may not accurately reflect underlying pathology. The paraoptometric's role is to conduct objective assessments to verify or refute subjective complaints, ensuring that diagnostic decisions are based on verifiable clinical evidence. Professional reasoning. Paraoptometrics should approach neuro-ophthalmic assessments with a structured methodology. This involves understanding the specific cranial nerves involved, Roman 2, Roman 3, Roman 4, VI, and their functions related to vision, pupillary control, and eye movement. The process should begin with a review of the patient's history for any relevant symptoms. Objective testing should then proceed systematically, covering visual acuity, visual fields, pupillary responses, including size, shape, and reaction to light and near stimuli, and extraocular muscle function. Any deviations from normal should be meticulously documented. The paraoptometric must then communicate these findings clearly and concisely to the supervising clinician, highlighting any potential areas of concern that warrant further investigation. This systematic, evidence-based approach ensures that patient care is delivered competently and ethically, adhering to the standards set forth by the CPO certification. Question 5. The assessment process reveals a patient who is a busy professional with moderate astigmatism and dry eye symptoms. They express a strong desire for daily disposable contact lenses for convenience and to mitigate their dry eye concerns. Based on the CPO regulatory framework, what is the most appropriate course of action? Option A. Recommend rigid gas permeable (RGP) contact lenses as they generally offer better oxygen permeability and can sometimes be beneficial for dry eye. Option B. Fit the patient with standard soft spherical contact lenses and instruct them to use artificial tears frequently. Option C. Advise the patient that daily disposable lenses are not suitable due to their dry eye symptoms and suggest they consider glasses only. Option D. Proceed with fitting daily disposable toric soft contact lenses, ensuring proper assessment of tear film and lens fit to address both astigmatism and dry eye, and provide detailed care instructions. Correct answer is D. Proceed with fitting daily disposable toric soft contact lenses, ensuring proper assessment of tear film and lens fit to address both astigmatism and dry eye, and provide detailed care instructions. Explanation. The assessment process reveals a patient presenting with specific visual needs and lifestyle considerations that necessitate careful selection and fitting of contact lenses. This scenario is professionally challenging because the paraoptometric must not only understand the technical aspects of different contact lens types, but also apply this knowledge within the strict regulatory framework governing optometric practice, ensuring patient safety, efficacy of treatment, and adherence to professional standards. The decision-making process requires a nuanced understanding of the patient's ocular health, visual demands, and the limitations and benefits of various lens modalities, all while operating within the scope of practice defined by CPO regulations. The correct approach involves a comprehensive evaluation of the patient's visual acuity, refractive error, corneal health, tear film stability, and lifestyle. This leads to the selection of a contact lens type, e.g., soft spherical toric multifocal rigid gas permeable, that best addresses these factors. The fitting principles, including base curve, diameter, and power, must be meticulously applied to ensure optimal lens centration, movement, and comfort, thereby minimizing the risk of complications. Post-fitting care and maintenance instructions, emphasizing hygiene and regular follow-up, are crucial for long-term ocular health and successful contact lens wear. This approach aligns with the CPO's responsibility to provide safe and effective vision care, adhering to the ethical imperative of patient well-being and the regulatory requirement to practice within one's competency and scope. An incorrect approach would be to recommend a contact lens type based solely on the patient's stated preference, without a thorough clinical assessment. This fails to consider potential contraindications or suboptimal outcomes, potentially leading to discomfort, reduced visual acuity, or even ocular pathology, which violates the duty of care and regulatory expectations for patient safety. Another incorrect approach is to provide inadequate or generic care and maintenance instructions. This neglects the critical role of proper lens hygiene in preventing infections and complications, thereby failing to meet the standard of care and potentially contravening CPO guidelines on patient education and risk mitigation. Furthermore, attempting to fit a lens type or manage a complication outside the paraoptometric's defined scope of practice would be a direct violation of regulatory boundaries, posing a significant risk to the patient and jeopardizing professional licensure. Professionals should employ a systematic decision-making framework that prioritizes patient assessment, clinical findings, and regulatory compliance. This involves 1. Thoroughly gathering patient history and performing a comprehensive ocular examination. 2. Identifying the patient's specific visual needs and lifestyle requirements. 3. Evaluating the suitability of different contact lens types based on clinical data and contraindications. 4. Applying established fitting principles to achieve optimal lens performance and comfort. 5. Providing clear, individualized instructions on lens care, handling, and follow-up. 6. Documenting all findings, decisions, and patient instructions meticulously. 7. Recognizing the limits of one's scope of practice and referring to a supervising optometrist when necessary. Question 6. Compliance review shows a paraoptometric's documentation regarding a patient's suspected superior oblique palsy. The paraoptometric correctly identified the primary actions of the superior oblique muscle as intorsion, depression, and abduction. Which of the following accurately describes the origin, insertion, and innervation of the superior oblique muscle? Option A. Originates from the orbital apex, inserts on the superior temporal sclea, and is innervated by the trochlear nerve CN Roman 4. Option B. Originates from the orbital apex, inserts on the inferior nasal sclea, and is innervated by the oculomotor nerve CN Roman 3. Option C. Originates from the trochlea, inserts on the superior temporal sclea, and is innervated by the trochlear nerve CN Roman 4. Option D. Originates from the annulus of Zinn, inserts on the superior temporal sclea, and is innervated by the oculomotor nerve CN Roman 3. The correct answer is A. Originates from the orbital apex, inserts on the superior temporal sclera and is innervated by the trochlear nerve CN Roman 4. Explanation. Scenario analysis. This scenario presents a professional challenge because it requires a paraoptometric to accurately identify the function of specific extraocular muscles based on their origin, insertion, and innervation. Misidentifying these components can lead to incorrect assessments of eye movement disorders, improper recommendations for vision therapy, or miscommunication with the supervising optometrist. The challenge lies in applying theoretical knowledge of ocular anatomy and physiology to a practical clinical context, ensuring patient care is based on sound diagnostic principles. Correct approach analysis. The correct approach involves accurately recalling and applying the anatomical and physiological knowledge of the superior oblique muscle. This includes understanding its origin, trochlea, insertion, superior temporal sclera, action, intorsion, depression, abduction, and innervation, cranial nerve Roman 4, the trochlear nerve. This precise knowledge is fundamental to the paraoptometric's role in assisting with the diagnosis and management of strabismus and other binocular vision anomalies, directly aligning with the scope of practice and the need for accurate clinical data as outlined by CPO certification standards. Incorrect approaches analysis. An incorrect approach would be to confuse the superior oblique with other extraocular muscles, such as the inferior oblique. For instance, attributing the primary action of intorsion and depression to the inferior oblique, or incorrectly stating its innervation, demonstrates a failure to grasp the distinct role and anatomical pathways of each muscle. This would violate the CPO's responsibility to provide accurate clinical information and could lead to diagnostic errors. Another incorrect approach would be to misidentify the innervation, for example, attributing the superior oblique to cranial nerve Roman 3 oculomotor nerve, instead of cranial nerve Roman 4, trochlear nerve. This highlights a fundamental misunderstanding of the cranial nerve control of eye movements, which is a core competency for a paraoptometric. Finally, an incorrect approach might involve conflating origin and insertion points, or misstating the direction of muscle pull and its resultant action. This demonstrates a lack of detailed anatomical understanding essential for clinical application. Professional reasoning. Professionals should approach such questions by systematically recalling the key characteristics of each extraocular muscle. A decision-making framework would involve 1. Identifying the specific muscle in question. 2. Recalling its origin and insertion points. 3. Identifying its primary and secondary actions. And 4. Confirming its cranial nerve innervation. If unsure, cross-referencing with approved CPO study materials or consulting with the supervising optometrist is the appropriate course of action, rather than guessing or providing inaccurate information. Question 7. Research into a patient presenting with acute onset of unilateral orbital pain, eyelid swelling, and mild photophobia, where initial visual acuity is 20/25, in the affected eye and extraocular movements appear slightly restricted. Given the paraoptometric's understanding of the anatomy of the orbit and its contents, which of the following risk assessment approaches is most appropriate to ensure optimal patient care within the certified paraoptometric (CPO) regulatory framework? Option A. Conduct a comprehensive assessment of the orbital structures, including detailed history, visual acuity, pupillary response, extraocular muscle function, and palpation of the orbital rims and eyelids. And if any signs suggest deeper orbital involvement or significant inflammation, initiate immediate referral to an ophthalmologist. Option B. Advise the patient to monitor symptoms for 48 hours and return if they worsen, without further examination of the orbital structures. Option C. Focus solely on managing the eyelid swelling with warm compresses and topical antibiotic ointment, assuming a benign sty or chalazion. Option D. Prescribe oral pain medication and recommend over-the-counter anti-inflammatory drops, deferring any specialized examination until the patient's next scheduled appointment. The correct answer is C. Focus solely on managing the eyelid swelling with warm compresses and topical antibiotic ointment, assuming a benign sty or chalazion. Explanation. This scenario is professionally challenging because it requires the paraoptometric to integrate knowledge of orbital anatomy with a patient's subjective complaint and objective findings, necessitating a careful risk assessment to ensure patient safety and appropriate referral. The paraoptometric must recognize that symptoms like pain, swelling, and visual changes in the orbital region can indicate serious conditions requiring immediate medical attention, potentially involving structures beyond the scope of routine optometric care. The correct approach involves a thorough assessment of the orbital anatomy and its contents, correlating the patient's symptoms with potential pathologies affecting the bony orbit, orbital muscles, nerves, vessels, eyelids, conjunctiva, or lacrimal system. This includes a detailed history, visual acuity testing, pupillary assessment, extraocular muscle evaluation, and palpation of the orbital rims and eyelids. If any signs or symptoms suggest a significant orbital issue, such as proptosis, restricted eye movements, diplopia, significant pain, or signs of infection or inflammation, the paraoptometric must escalate care by referring the patient to an ophthalmologist or emergency services. This aligns with the CPO's scope of practice, which emphasizes patient care and timely referral for conditions requiring specialized medical management. As outlined in the CPO's ethical guidelines and regulatory framework that mandate acting in the best interest of the patient and recognizing the limits of their professional expertise. An incorrect approach would be to dismiss the patient's symptoms as minor or to attempt management without a comprehensive understanding of the potential orbital involvement. For instance, if the paraoptometric focuses solely on a superficial eyelid condition like a stye and fails to consider deeper orbital inflammation or infection, they risk delaying critical diagnosis and treatment. This failure to recognize the potential severity of orbital pathology constitutes a breach of professional duty and could lead to adverse patient outcomes, violating ethical principles of beneficence and non-maleficence. Another incorrect approach would be to provide a definitive diagnosis of a complex orbital condition without the necessary diagnostic tools or specialized training, exceeding the paraoptometric scope of practice and potentially misinforming the patient and delaying appropriate specialist care. This also contravenes regulatory guidelines that define the boundaries of paraoptometric practice. Professional decision-making in such situations should follow a structured process. 1. Gather comprehensive patient history and subjective complaints. 2. Perform a thorough objective examination, specifically assessing the relevant anatomical structures, orbit, eyelids, conjunctiva, lacrimal system, extraocular muscles, pupils. 3. Correlate findings with potential diagnoses, considering the differential diagnoses for orbital region symptoms. 4. Assess the risk of serious pathology based on the findings. 5. Determine if the condition falls within the paraoptometric scope of practice for management or requires referral. 6. If referral is indicated, ensure timely and appropriate communication with the referring physician or facility. Question 8. To address the challenge of a patient asking about the colored part of their eye that seems to change size, what is the most accurate and educationally sound approach for a certified paraoptometric to take when identifying and explaining this anatomical structure? Option A. Identify the structure as the iris and explain that it controls the amount of light entering the eye by adjusting the size of the pupil. Option B. Identify the structure as the cornea and describe it as the clear outer covering of the eye. Option C. Identify the structure as the lens and explain that it focuses light onto the back of the eye. Option D. Identify the structure as the pupil and explain that it is the colored part of the eye that changes size. The correct answer is A. Identify the structure as the iris and explain that it controls the amount of light entering the eye by adjusting the size of the pupil. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the paraoptometric to accurately identify and communicate anatomical structures of the globe to a patient who may have limited medical knowledge. Misidentification or miscommunication can lead to patient anxiety, misunderstanding of their condition, and potentially noncompliance with treatment or follow-up recommendations. The paraoptometric must balance providing clear, understandable information with maintaining professional accuracy and adhering to scope of practice. Correct approach analysis. The correct approach involves the paraoptometric accurately identifying the structure as the iris and explaining its function in controlling light entry into the eye. This is correct because the iris is a distinct anatomical structure within the anterior segment of the globe, responsible for pupillary light reflex. The paraoptometric's role includes patient education within their scope of practice, and accurately naming and describing the iris aligns with this responsibility. This approach upholds the ethical principle of beneficence by ensuring the patient receives accurate information to understand their eye health. Incorrect approach is analysis, an approach that identifies the structure as the pupil and describes it as the colored part of the eye is incorrect. While the pupil is related to the iris, it is the opening within the iris. The colored part is the iris itself. This misidentification demonstrates a lack of precise anatomical knowledge, which can lead to patient confusion and a breakdown in effective communication. It fails to meet the standard of accuracy expected in patient education. An approach that identifies the structure as the lens and explains it focuses light is incorrect. Lens is located posterior to the iris and pupil and has a different anatomical position and primary function, refraction for focusing on near objects. Confusing the iris with the lens represents a significant anatomical error, undermining the paraoptometric's credibility and potentially leading to misinformed patient understanding of their visual system. An approach that identifies the structure as the cornea and describes it as the clear outer covering of the eye is incorrect. The cornea is the transparent front part of the eye that covers the iris, pupil, and anterior chamber. While it is an anterior structure, it is distinct from the iris. This misidentification shows a failure to differentiate between key anterior segment structures, which is a fundamental anatomical error. Professional reasoning. When faced with identifying anatomical structures for patient education, a paraoptometric should follow a systematic approach. 1. Accurate visual identification. Carefully observe the structure in question. 2. Precise anatomical recall. Access and apply knowledge of ocular anatomy, ensuring correct naming and location of structures. 3. Clear and concise explanation. Communicate the function of the identified structure in simple, understandable terms, avoiding jargon. 4. Scope of practice adherence. Ensure the explanation remains within the paraoptometric's defined professional scope, focusing on education and information dissemination rather than diagnosis or treatment. 5. Patient comprehension check. Verify that the patient understands the information provided. Question 9. Analysis of a scenario where a certified paraoptometric CPO is performing lensometry on a patient's current eyeglasses. The readings for the right lens show a spherical power of -3, 0, with -1, 0 cylinder at 180 degrees. However, upon rechecking, the CPO consistently obtains a reading of -4, 50 with -1, 0 cylinder at 180 degrees for the same lens. The patient reports no significant change in their vision and has not had a recent prescription update. What is the most appropriate course of action for the CPO? Option A. Assume the initial reading was correct and proceed with documenting -3, 0 sphere as the patient reports no change in vision, implying the current lenses are adequate. Option B. Adjust the lensometry equipment calibration and remeasure the lens, assuming the equipment is faulty and the -3, 0 reading is likely the accurate one. Option C. Document the discrepancy in the patient's chart, noting both readings obtained, and immediately inform the supervising optometrist of the significant difference and the patient's subjective report. Option D. Remeasure the lens multiple times, and if the -4, 50 reading persists, inform the patient that their current lenses are significantly stronger than their prescription and may be causing harm. The correct answer is C. Document the discrepancy in the patient's chart, noting both readings obtained, and immediately inform the supervising optometrist of the significant difference and the patient's subjective report. Explanation. This scenario is professionally challenging because it requires the paraoptometric to interpret potentially ambiguous lensometry readings and understand the implications for patient care and regulatory compliance. The paraoptometric must not only accurately measure lens characteristics, but also recognize when those measurements deviate from expected norms or indicate a potential issue that requires further professional evaluation. The Certified Paraoptometric (CPO) certification implies a level of competency and responsibility that extends beyond simple measurement to include critical assessment and appropriate action. The correct approach involves recognizing that a significant and unexpected change in lens power, particularly when compared to previous records or the patient's reported visual experience, warrants further investigation by the optometrist. This aligns with the CPO's ethical obligation to act in the best interest of the patient and to practice within the scope of their certification. Regulatory frameworks for paraoptometrics emphasize the importance of accurate data collection and the necessity of escalating findings that may impact patient health or the accuracy of prescribed vision correction. The CPO must understand that while they are skilled in lensometry, they are not authorized to diagnose or definitively interpret the cause of such discrepancies without optometrist oversight. Therefore, documenting the findings and bringing them to the optometrist's attention is the most responsible and compliant course of action. An incorrect approach would be to dismiss the significant change in lens power as a minor anomaly, or to assume it is a measurement error without proper verification. This could lead to the patient continuing to wear incorrect prescription lenses, potentially causing visual discomfort, eye strain, or even exacerbating underlying refractive conditions. Ethically, this fails to uphold the duty of care owed to the patient. From a regulatory standpoint, it could be seen as a failure to perform duties diligently and to ensure the accuracy of information provided to the optometrist. Another incorrect approach would be to immediately assume the patient's previous prescription was incorrect or that the new lenses are faulty without a thorough recheck and consultation with the optometrist. While these are possibilities, jumping to conclusions without a systematic process of verification and professional consultation is premature and unprofessional. It bypasses the necessary steps of accurate data gathering and collaborative decision-making, which are fundamental to patient care and regulatory compliance. The professional reasoning process for such situations should involve a systematic approach. 1. Accurate measurement. Ensure the lensometry is performed correctly and rechecked if any doubt exists. 2. Comparison and context. Compare current readings with previous records and consider the patient's subjective visual complaints. 3. Identification of significant deviations. Recognize when measurements fall outside expected parameters or show a substantial change. 4. Escalation. Bring significant findings to the attention of the supervising optometrist for further evaluation and decision-making. 5. Documentation. Meticulously record all measurements, observations, and actions taken. This structured approach ensures that patient care is prioritized, regulatory requirements are met, and the paraoptometric operates effectively within their scope of practice. Question 10. The investigation demonstrates a patient presenting with a chief complaint of difficulty seeing distant objects clearly. Objective measurements from the autorefractor and retinoscopy indicate a consistent finding of myopia. The paraoptometric is tasked with correlating these findings to assist the optometrist. Which of the following approaches best reflects the paraoptometric's role in this scenario? Adhering to the principles of refraction and the Certified Paraoptometric (CPO) framework. Option A. Advise the patient that their vision is likely to worsen over time due to the diagnosed myopia without further correlation of findings. Option B. Assume the patient's complaint is a direct result of the measured myopia and proceed to suggest a specific lens power to correct it. Option C. Document the objective findings of myopia and present them to the optometrist, noting the patient's complaint of blurred distance vision. Option D. Focus solely on the autorefractor readings and disregard the patient's subjective report of blurred distance vision as potentially unreliable. The correct answer is C. Document the objective findings of myopia and present them to the optometrist, noting the patient's complaint of blurred distance vision. Explanation. The investigation demonstrates a common challenge in paraoptometric practice, accurately interpreting subjective patient responses to objective optical findings. The professional challenge lies in synthesizing the patient's reported visual experience with the optometrist's objective measurements to arrive at the most appropriate refractive correction. This requires not only a thorough understanding of optical principles, but also adherence to ethical guidelines regarding patient care and scope of practice. The correct approach involves carefully correlating the patient's subjective complaints of blurred vision at distance with the objective findings of myopia, as indicated by the retinoscopy and autorefractor. This approach prioritizes the patient's reported symptoms and aligns them with the optical principles of myopia, where light focuses in front of the retina, causing distant objects to appear blurry. The paraoptometric's role is to facilitate this correlation and present the findings clearly to the optometrist for final prescription. This aligns with the Certified Paraoptometric (CPO) certification's emphasis on assisting the optometrist in comprehensive eye care, ensuring patient comfort and visual acuity are paramount. Ethical practice dictates that patient-reported symptoms are a critical component of the diagnostic process. An incorrect approach would be to solely rely on the objective measurements without considering the patient's subjective experience. For instance, if the paraoptometric were to dismiss the patient's complaint of blurred distance vision, despite objective findings of myopia, this would be a failure to integrate subjective and objective data, potentially leading to an inadequate or incorrect prescription. This disregards the fundamental principle that the patient's perception of their vision is a primary indicator of refractive error. Another incorrect approach would be to attempt to diagnose or prescribe based on assumptions rather than a systematic correlation of findings. This could involve suggesting a correction based on a general understanding of refractive errors without specific patient data, which falls outside the paraoptometric's defined scope of practice and could lead to patient harm. The professional decision-making process in such a scenario should involve a systematic review of all collected data, objective measurements, autorefractor, retinoscopy, and subjective patient reports, visual acuity, symptom description. The paraoptometric must then synthesize these findings, identifying any discrepancies or confirmations. The next step is to communicate these synthesized findings clearly and concisely to the supervising optometrist, highlighting the correlation between objective findings and subjective complaints. This ensures that the optometrist has all necessary information to make an informed diagnostic and prescriptive decision, prioritizing patient well-being and visual outcomes. Question 11. During the evaluation of a patient reporting significant blurred vision, retinoscopy reveals a perfectly neutral red reflex with no discernible movement of the light reflex, suggesting emmetropia. However, the patient consistently reports difficulty seeing distant objects clearly. What is the most appropriate next step for the paraoptometric? Option A. Adjust the retinoscopic findings to align with the patient's subjective complaint, assuming the objective measurement was inaccurate due to poor patient cooperation. Option B. Conclude that the patient's subjective complaint is likely due to factors unrelated to refractive error, such as dry eye or fatigue, and proceed with a standard subjective refraction without further investigation into the retinoscopic findings. Option C. Immediately administer cycloplegic drops to relax accommodation and reevaluate the refractive error, assuming the discrepancy is due to significant accommodative effort during the initial retinoscopy. Option D. Acknowledge the retinoscopic findings of neutrality and proceed to subjective refraction, carefully noting the patient's subjective complaints and exploring potential reasons for the discrepancy, such as accommodative issues or fixation disparity, before finalizing a prescription. The correct answer is D. Acknowledge the retinoscopic findings of neutrality and proceed to subjective refraction, carefully noting the patient's subjective complaints and exploring potential reasons for the discrepancy, such as accommodative issues or fixation disparity, before finalizing a prescription. Explanation. This scenario is professionally challenging because it requires the paraoptometric to interpret subjective patient responses in conjunction with objective retinoscopic findings, ensuring the final prescription accurately reflects the patient's visual needs and is ethically sound. The paraoptometric must balance the precision of retinoscopy with the patient's subjective experience to avoid prescribing an inaccurate correction. The correct approach involves carefully considering the retinoscopic findings, particularly the neutrality of the red reflex and the absence of any movement, which indicates emmetropia or a very low refractive error. This objective finding is then critically evaluated against the patient's subjective report of blurred vision. When there is a discrepancy, the paraoptometric must prioritize further investigation and patient communication over immediately accepting the retinoscopic neutrality as the definitive answer for a patient reporting blur. This aligns with the ethical obligation to provide competent care and to ensure patient satisfaction and visual well-being, as mandated by paraoptometric practice standards that emphasize thoroughness and patient-centered care. The paraoptometric is expected to use all available tools and information to arrive at the most accurate prescription, which includes not dismissing subjective complaints solely based on an initial objective finding. An incorrect approach would be to solely rely on the retinoscopic finding of neutrality and dismiss the patient's complaint of blurred vision without further investigation. This fails to acknowledge the limitations of retinoscopy, which can sometimes be influenced by factors like accommodation or patient cooperation, and more importantly, it disregards the patient's subjective experience, which is a critical component of refraction. Ethically, this approach could lead to an inaccurate prescription, potentially causing patient dissatisfaction and compromising visual function, which violates the duty of care. Another incorrect approach would be to immediately assume the patient is experiencing accommodative spasm or other subjective issues and proceed with cycloplegic refraction without first attempting to resolve the discrepancy through other means, such as re-evaluating the retinoscopy, checking for fixation disparity, or discussing potential causes of blur with the patient. While cycloplegia is a tool, it should be employed judiciously and not as a first resort when a simpler explanation or resolution might exist. This approach might be overly aggressive and not the most efficient or patient-friendly initial step. A further incorrect approach would be to adjust the retinoscopic findings to match the patient's subjective complaint without a clear, objective rationale. This undermines the integrity of the objective measurement and could lead to an overcorrected or undercorrected prescription, failing to meet the standard of care for accurate refractive assessment. Professional decision-making in such situations requires a systematic approach. First, confirm the objective findings, retinoscopy. Second, thoroughly investigate the subjective complaint. Third, identify and address any discrepancies through further testing or patient dialogue. And finally, formulate a prescription that best balances objective data with subjective visual experience, always prioritizing patient safety and visual outcomes. Question 12. The control framework reveals that when a patient expresses a strong preference for a particular spectacle lens material, a paraoptometric must consider various factors beyond the patient's stated desire. Which of the following approaches best demonstrates adherence to professional standards and patient-centered care in this scenario? Option A. Suggesting a standard plastic lens material for all patients, unless they specifically ask for something different, to simplify the selection process and avoid overwhelming them with choices. Option B. Prioritizing the recommendation of the most advanced and feature-rich lens material available, regardless of the patient's prescription or daily activities, to ensure they receive the latest technology. Option C. Explaining the properties, benefits, and potential drawbacks of the requested lens material, and then discussing alternative materials and coatings that might better suit the patient's visual needs, lifestyle, and prescription, before collaboratively making a final decision. Option D. Recommending the lens material the patient explicitly requested, assuming their research or prior experience makes it the optimal choice. The correct answer is D. Recommending the lens material the patient explicitly requested, assuming their research or prior experience makes it the optimal choice. Explanation. The control framework reveals that a paraoptometric must exercise sound judgment when recommending spectacle lens types, materials, and coatings to patients. This scenario is professionally challenging because the paraoptometric must balance the patient's perceived needs and preferences with evidence-based recommendations that ensure optimal visual correction, comfort, and durability, all while adhering to professional standards and ethical obligations. The risk lies in recommending a lens that, while meeting a superficial request, may not be the most appropriate for the patient's visual demands, lifestyle, or ocular health, potentially leading to dissatisfaction or suboptimal vision. The correct approach involves a thorough patient assessment that goes beyond simply asking about preferences. It requires understanding the patient's visual tasks, environment, and any specific concerns they may have. Based on this comprehensive understanding, the paraoptometric can then recommend lens types, materials, and coatings that are best suited to their needs. For example, recommending polycarbonate lenses for a child who plays sports due to their impact resistance, or suggesting anti-reflective coating for a patient who experiences glare from computer screens, aligns with professional best practices and ethical duty to provide the most beneficial solution. This approach prioritizes patient well-being and visual performance, which is a core tenet of paraoptometric practice. An incorrect approach would be to solely rely on the patient's stated preference without further investigation. For instance, if a patient requests a specific lens material without understanding its properties or limitations, simply fulfilling that request without explaining alternatives or potential drawbacks could lead to a suboptimal outcome. This fails to uphold the paraoptometric's responsibility to educate and guide the patient towards the best possible solution. Another incorrect approach would be to recommend the most expensive lens option without a clear justification based on the patient's needs, potentially leading to overprescription and financial burden on the patient, which is ethically questionable. Recommending a lens material that is unsuitable for the patient's prescription or lifestyle, such as a high-index lens for a very low prescription, where it offers no significant benefit, also represents a failure to apply professional knowledge effectively. Professionals should employ a decision-making process that begins with active listening and thorough patient history taking. This should be followed by a comprehensive visual assessment and a discussion of potential lens options, explaining the benefits and drawbacks of each in relation to the patient's specific needs and lifestyle. The paraoptometric should then collaboratively decide on the best course of action with the patient, ensuring informed consent and patient satisfaction. Question 13. Quality control measures reveal that a patient's Humphrey visual field test shows a generalized depression of sensitivity in the superior peripheral field, with a distinct nasal step defect noted in the inferior nasal quadrant. The patient is 65 years old and reports no specific visual complaints. Which of the following approaches best reflects the paraoptometric's responsibility in interpreting these results? Option A. Note the generalized depression and nasal step defect. Correlate these with the patient's age and lack of symptoms, and flag the findings for the supervising optometrist's immediate review due to the potential for early glaucomatous changes. Option B. Advise the patient that their peripheral vision is declining due to their age and suggest they return in 2 years for another test. Option C. Document the findings as normal age-related peripheral vision changes and proceed with routine follow-up. Option D. Focus only on the nasal step defect, as this is a classic sign of glaucoma, and disregard the generalized depression as nonspecific. The correct answer is C. Document the findings as normal age-related peripheral vision changes and proceed with routine follow-up. Explanation. Scenario analysis. This scenario presents a challenge in interpreting visual field results, specifically concerning the identification of subtle peripheral vision loss. The paraoptometric must accurately differentiate between normal age-related changes and potential pathological findings that require further investigation. Misinterpretation could lead to delayed diagnosis and treatment, impacting patient outcomes. The professional challenge lies in applying knowledge of visual field anatomy and parametry techniques to a specific patient presentation, ensuring adherence to established diagnostic protocols and ethical responsibilities. Correct approach analysis. The correct approach involves systematically analyzing the visual field printout, correlating findings with the patient's age and medical history, and identifying specific patterns of visual field defect. This aligns with the Certified Paraoptometric (CPO) scope of practice, which includes assisting in the interpretation of diagnostic tests under the supervision of an optometrist. Regulatory guidelines for CPOs emphasize accurate data collection and preliminary analysis to support the optometrist's diagnostic decisions. This approach ensures that all relevant information is considered, leading to a more accurate assessment and appropriate referral or management plan. Incorrect approaches analysis. One incorrect approach is to dismiss any peripheral vision loss as a normal consequence of aging without further investigation. This fails to acknowledge that significant visual field defects can occur due to various ocular diseases, e.g., glaucoma, retinal detachment, and that not all age-related changes are benign. Ethically, this approach neglects the duty of care to identify potential vision-threatening conditions. Another incorrect approach is to focus solely on the most obvious areas of visual field loss and overlook subtle, early-stage defects in other quadrants. This demonstrates a lack of thoroughness in parametry interpretation, potentially missing early indicators of disease progression. Regulatory frameworks for allied health professionals stress comprehensive analysis of diagnostic data. A third incorrect approach is to rely on automated software interpretations without critically evaluating the raw data and the patient's clinical presentation. While software can be a helpful tool, it is not a substitute for professional judgment. Over-reliance on automation can lead to overlooking artifacts or misinterpreting complex patterns, violating the principle of competent practice. Professional reasoning. Professionals should approach visual field interpretation by first understanding the anatomy of the visual field and the principles of the parametry technique used. They should then systematically review the visual field printout, paying attention to the overall pattern of sensitivity, the presence of specific defects, e.g., arcuate scotomas, nasal steps, and the reliability indices. This should be done in conjunction with the patient's age, refractive error, and any relevant medical history. If any significant or suspicious findings are noted, the paraoptometric should flag these for the supervising optometrist's review adhering to established protocols for reporting and referral. This systematic and critical evaluation ensures that patient care is based on accurate and complete information. Question 14. Comparative studies suggest that the accuracy of cover test techniques in assessing ocular alignment and phorias/tropias can be influenced by the specific methodology employed. A paraoptometric is tasked with evaluating a patient who reports intermittent blurred vision and occasional double vision, particularly when reading. Considering the Certified Paraoptometric (CPO) scope of practice and the need for comprehensive binocular vision assessment, which of the following approaches best ensures the detection and quantification of potential binocular vision anomalies contributing to the patient's symptoms? Option A. Perform a unilateral cover test at near, observing the movement of the uncovered eye when the fellow eye is occluded. Option B. Perform an alternating cover test for both distance and near, ensuring complete occlusion and observing for refixation movements of the uncovered eye. Option C. Execute an alternating cover test at distance, but only use a partially occluding lens at near to assess accommodative convergence. Option D. Conduct a unilateral cover test at distance only, focusing on the movement of the covered eye when it is uncovered. The correct answer is B. Perform an alternating cover test for both distance and near, ensuring complete occlusion and observing for refixation movements of the uncovered eye. Explanation. This scenario presents a professional challenge in accurately assessing ocular alignment and phorias/tropias, which is fundamental to the paraoptometric scope of practice as defined by the Certified Paraoptometric (CPO) certification. The challenge lies in selecting the most appropriate cover test technique based on the patient's presentation and the specific diagnostic goals, ensuring that the assessment is both thorough and efficient, adhering to established clinical protocols and ethical standards. Careful judgment is required to differentiate between latent phoria and manifest tropia deviations and to quantify their magnitude and direction, which directly impacts the subsequent management plan. The correct approach involves systematically performing a cover test that accounts for both distance and near viewing conditions, and utilizing appropriate occluders to elicit and observe eye movements. This method, often referred to as alternating cover testing, is the gold standard for detecting and quantifying phorias and tropias. It directly aligns with the CPO's responsibility to assist the optometrist in diagnosing and managing binocular vision disorders. The regulatory framework for CPOs emphasizes the importance of accurate data collection to support clinical decision-making. By employing a comprehensive cover test, the paraoptometric fulfills their duty to provide reliable information, thereby upholding professional standards in patient care. An incorrect approach would be to solely perform a unilateral cover test without alternating the occluder. This technique is primarily effective in identifying manifest deviations, tropias, but is less sensitive to latent deviations, phorias. Failing to alternate the occluder can lead to an underestimation or complete miss of a phoria, which, if uncorrected, can contribute to symptoms like eye strain, headaches, or blurred vision. This omission represents a failure to gather complete diagnostic data, potentially hindering the optometrist's ability to formulate an accurate diagnosis and treatment plan, and thus falling short of the expected standard of care. Another incorrect approach would be to perform the cover test only at distance and neglect the near assessment. Binocular vision status can change significantly between distance and near viewing. A patient might have orthophoria at distance but a significant esophoria or exophoria at near, or vice versa. Omitting the near cover test means that a crucial aspect of the patient's binocular function is not evaluated, leading to an incomplete picture of their visual system. This oversight can result in misdiagnosis and inappropriate management, as treatment strategies often differ based on whether the deviation is present at distance, near, or both. A third incorrect approach would be to use an occluder that is not opaque or to allow light to leak around the occluder during the test. This compromises the integrity of the cover test by not fully dissociating the visual axis of the eyes. If one eye can still perceive the target, the reflex to fixate may not be fully suppressed, leading to inaccurate observations of eye movements. This technical flaw undermines the reliability of the data collected and can lead to misinterpretation of the patient's binocular status, failing to meet the CPO's obligation to perform diagnostic tests with precision and accuracy. The professional decision-making process for similar situations should involve a systematic review of the patient's chief complaint and visual history, followed by the selection of appropriate diagnostic tests based on the suspected condition. For binocular vision assessments, this includes understanding the nuances of different cover test variations and their specific applications. Professionals should always prioritize techniques that provide the most comprehensive and accurate data within their scope of practice, adhering strictly to established clinical guidelines and regulatory requirements. When in doubt, consulting with the supervising optometrist is a critical step in ensuring optimal patient care. Question 15. The monitoring system demonstrates a patient's visual acuity being recorded as 20/40 using a tumbling E chart and subsequently as 20/30 using a Snellen chart during a follow-up examination. Which of the following represents the most appropriate interpretation and subsequent action for the paraoptometric? Option A. Recognize that the tumbling E and Snellen charts are not directly interchangeable and investigate potential reasons for the discrepancy, such as changes in visual function, chart distance, or patient understanding, before concluding a change in visual acuity. Option B. Document both readings as recorded but consider them equivalent for the purpose of tracking visual changes, as both charts are standard visual acuity tests. Option C. Conclude that the patient's vision has improved by one line on the Snellen equivalent, as 20/30 is better than 20/40, and update the patient's record accordingly. Option D. Assume the initial measurement with the tumbling E chart was inaccurate and prioritize the Snellen chart result as the definitive measure of the patient's current visual acuity. The correct answer is A. Recognize that the tumbling E and Snellen charts are not directly interchangeable and investigate potential reasons for the discrepancy, such as changes in visual function, chart distance, or patient understanding, before concluding a change in visual acuity. Explanation. The monitoring system demonstrates a scenario where a paraoptometric must interpret visual acuity results obtained using different charts. This is professionally challenging because the choice of chart and the patient's ability to cooperate or understand instructions can significantly influence the recorded acuity, potentially leading to misinterpretations of visual status or progression. Accurate measurement and documentation are paramount for patient care, treatment planning, and legal compliance within the Certified Paraoptometric (CPO) framework. The correct approach involves recognizing that different visual acuity charts are designed for specific purposes and patient populations, and their results are not always directly interchangeable without consideration of these factors. For instance, the Snellen chart is a standard for distance acuity, while the tumbling E or Allen picture chart is used for preliterate children or individuals with communication barriers. Acknowledging these differences and selecting the most appropriate chart for the patient's age, cognitive ability, and the clinical question being addressed is crucial. This aligns with CPO ethical guidelines emphasizing accurate data collection and patient-centered care, ensuring that the visual acuity measurement truly reflects the patient's functional vision. An incorrect approach would be to assume that a visual acuity measurement taken with one type of chart is directly equivalent to a measurement taken with another, without accounting for the chart's design and intended use. For example, using a Snellen chart for a young child who cannot identify letters would yield unreliable results and misrepresent their visual capabilities. Similarly, failing to document which chart was used can lead to confusion in follow-up examinations or when comparing results over time. This failure to use appropriate tools and document them accurately violates the CPO's responsibility to maintain precise patient records and provide competent care. Another incorrect approach would be to prioritize speed over accuracy, rushing through the acuity test without ensuring the patient understands the instructions or is positioned correctly, leading to potentially inaccurate readings. This disregards the fundamental principle of obtaining reliable data for effective patient management. Professionals should employ a decision-making framework that prioritizes patient assessment and selection of the most appropriate diagnostic tools. This involves understanding the limitations and applications of various visual acuity charts, considering the patient's individual characteristics, and meticulously documenting the testing method. When faced with ambiguous results or challenging patient situations, seeking guidance from a supervising optometrist or ophthalmologist is a critical step in ensuring accurate diagnosis and appropriate care. Question 16. Investigation of a patient presenting with a history of gradual, painless peripheral vision loss and optic nerve head cupping coupled with consistently normal intraocular pressure readings, leads to a need for precise diagnostic interpretation. Which of the following diagnostic and management approaches best reflects the paraoptometric's role in supporting the diagnosis and management of this patient's suspected glaucoma? Option A. Document the findings of optic nerve head cupping and peripheral vision loss, note the normal intraocular pressure, and present this comprehensive data to the supervising optometrist for further diagnostic workup and management planning. Option B. Focus solely on the normal intraocular pressure readings and dismiss the optic nerve head changes and reported vision loss as unrelated. Option C. Advise the patient that their vision loss is likely due to aging and no further investigation is necessary. Option D. Recommend immediate initiation of topical hypotensive medication and schedule a follow-up visual field test in 6 months. The correct answer is D. Recommend immediate initiation of topical hypotensive medication and schedule a follow-up visual field test in 6 months. Explanation. This scenario is professionally challenging because it requires the paraoptometric to accurately identify and differentiate between various types of glaucoma, understand the diagnostic implications of specific findings, and propose appropriate management strategies within the scope of their practice and under the supervision of an optometrist or ophthalmologist. The paraoptometric must demonstrate a thorough understanding of the nuances of glaucoma, moving beyond simple recognition to a more analytical approach to patient care. The correct approach involves a comprehensive assessment of the patient's visual field, intraocular pressure, IOP measurements, and optic nerve head evaluation, followed by the formulation of a differential diagnosis that considers the most likely type of glaucoma based on these findings. This approach is correct because it aligns with the Certified Paraoptometric (CPO) certification's emphasis on diagnostic skills and the ability to assist in the management of ocular conditions. Specifically, the CPO role involves gathering critical data that informs the optometrist's or ophthalmologist's diagnosis and treatment plan. The ability to recognize patterns indicative of different glaucoma types, e.g., open angle, angle closure, normal tension, and to suggest appropriate next steps for further investigation or management is a core competency. This directly supports the ethical obligation to provide accurate and thorough patient care, ensuring that the supervising clinician has the necessary information to make informed decisions. An incorrect approach would be to solely focus on a single diagnostic parameter, such as elevated IOP, without considering other crucial factors like optic nerve appearance or visual field defects. This is a regulatory and ethical failure because it oversimplifies the diagnosis of glaucoma, which is a complex disease with varied presentations. Relying on a single metric can lead to misdiagnosis, delayed treatment, or unnecessary interventions, violating the duty of care to the patient. Another incorrect approach would be to recommend specific treatments or prescribe medications without the direct authorization and supervision of a licensed optometrist or ophthalmologist. This is a significant regulatory and ethical violation, as it exceeds the scope of practice for a paraoptometric and could result in patient harm. The CPO's role is to support, not to independently practice optometry or ophthalmology. A third incorrect approach would be to dismiss the patient's symptoms or diagnostic findings as insignificant without further investigation. This demonstrates a lack of clinical judgment and a failure to recognize the potential severity of glaucoma, which can lead to irreversible vision loss. Ethically, this represents a dereliction of duty and a failure to act in the patient's best interest. The professional decision-making process for similar situations should involve a systematic evaluation of all available patient data, a thorough understanding of the differential diagnoses for the presenting signs and symptoms, and a clear awareness of the paraoptometric scope of practice and the importance of collaborative care with the supervising clinician. When faced with complex cases, the paraoptometric should prioritize accurate data collection, clear communication with the supervising clinician, and adherence to established protocols and ethical guidelines. Question 17. Benchmark analysis indicates that a paraoptometric is performing a comprehensive eye examination on a patient presenting with a history of intermittent dizziness. During the assessment of eye movements, the paraoptometric observes that the patient's saccades appear slightly imprecise when shifting gaze from a distant target to a near target, and their smooth pursuit of a moving object is occasionally jerky, with small corrective saccades. The patient reports no specific visual complaints related to these movements, What is the most appropriate course of action for the paraoptometric in this situation, considering their role and the potential clinical significance of these findings? Option A. Record that the eye movements were slightly off and proceed with the rest of the examination without further detailed notation or reporting to the optometrist. Option B. Advise the patient that their eye movements are normal and that the dizziness is likely unrelated to their vision, as they reported no specific visual complaints. Option C. Immediately inform the patient that their eye movements suggest a potential neurological issue and recommend they see a neurologist. Option D. Meticulously document the observed saccadic imprecision and jerky smooth pursuit, noting the presence of corrective saccades, and report these findings to the supervising optometrist for further evaluation. Correct answer is D. Meticulously document the observed saccadic imprecision and jerky smooth pursuit, noting the presence of corrective saccades, and report these findings to the supervising optometrist for further evaluation. Explanation. This scenario presents a professional challenge because the paraoptometric must accurately interpret subtle eye movement abnormalities and correlate them with potential underlying neurological or ocular conditions, all while adhering to the scope of practice defined by the Certified Paraoptometric (CPO) certification. The clinical significance of identifying specific types of eye movements, such as saccadic intrusions or impaired smooth pursuits, requires a thorough understanding of their implications for patient diagnosis and management. The paraoptometric's role is to gather objective data that assists the optometrist in making a definitive diagnosis and treatment plan. Misinterpreting these findings or failing to document them appropriately could lead to delayed or incorrect diagnoses, impacting patient care and potentially violating professional standards. The correct approach involves meticulously documenting the observed eye movements, noting their quality, speed, accuracy, and any associated symptoms reported by the patient. This detailed observation and recording are crucial for providing the optometrist with the necessary information to assess the patient's visual system. The clinical significance of saccades, pursuits, fixations, and vergence is well established in optometric practice. For instance, impaired saccadic accuracy can suggest cerebellar dysfunction, while deficits in smooth pursuit might indicate parietal lobe lesions. Inaccurate fixations can point to nystagmus or other visual processing issues. Abnormal vergence can be linked to binocular vision disorders. The CPO certification emphasizes the paraoptometric's responsibility in performing and documenting these tests accurately, contributing to a comprehensive eye examination. This aligns with the ethical obligation to provide competent patient care and uphold the standards of the profession. An incorrect approach would be to dismiss subtle abnormalities in eye movements as insignificant without further investigation or documentation. This fails to recognize the potential clinical significance of these findings, which could be early indicators of serious underlying conditions. Ethically, this constitutes a failure to act in the patient's best interest and a dereliction of duty to provide thorough patient care. Another incorrect approach would be to overstep the paraoptometric scope of practice by attempting to diagnose the condition based on the eye movement findings. The CPO role is to collect and report data, not to interpret it diagnostically. This overreach violates regulatory boundaries and professional ethics, potentially leading to misdiagnosis and harm to the patient. Finally, failing to document the observed eye movements or documenting them in a vague and unhelpful manner is also professionally unacceptable. Inaccurate or incomplete records hinder the optometrist's ability to assess the patient and can lead to continuity of care issues. This violates the professional standard of maintaining accurate and complete patient records. The professional reasoning process for similar situations should involve a systematic approach. First, accurately perform and document the requested eye movement tests according to established protocols. Second, critically evaluate the findings for any deviations from normal, considering the potential clinical significance of each observation. Third, clearly and concisely report these findings to the supervising optometrist, highlighting any abnormalities. Fourth, refrain from making diagnostic interpretations, understanding that this is the optometrist's responsibility. Finally, ensure all documentation is thorough, accurate, and compliant with the CPO scope of practice and ethical guidelines. Question 18. The performance metrics show a consistent, albeit slight, decrease in visual acuity in the right eye over the last 3 patient visits, while the patient reports no significant discomfort or changes in their vision. Option A. Advise the patient that their vision is stable and no further action is needed. Option B. Immediately refer the patient to a specialist without any further paraoptometric assessment. Option C. Continue with routine care. As the visual acuity remains within the broad acceptable range and the patient reports no issues. Option D. Recommend a follow-up appointment with the optometrist to discuss the trend and consider further diagnostic testing. Correct answer is D. Recommend a follow-up appointment with the optometrist to discuss the trend and consider further diagnostic testing. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the paraoptometric to interpret objective performance data in the context of subjective patient experience and potential underlying physiological changes. The challenge lies in moving beyond simply noting a metric to understanding its implications for patient care and the need for further investigation, all while adhering to professional standards and scope of practice. Correct approach analysis. The correct approach involves recognizing that a significant deviation in a performance metric, even if within a broad acceptable range, warrants further investigation. This aligns with the CPO's ethical responsibility to provide the highest quality of patient care and to identify potential issues that could impact vision or ocular health. The Certified Paraoptometric (CPO) certification emphasizes a commitment to patient well-being and the accurate assessment of visual function. This approach prioritizes patient safety and proactive care by not dismissing a trend that could indicate a developing problem. Incorrect approach is analysis. Dismissing the trend because it is within the broad acceptable range fails to acknowledge the importance of subtle but consistent changes. This approach neglects the paraoptometric's duty to observe and report deviations that could be early indicators of a condition, potentially leading to delayed diagnosis and treatment. Focusing solely on the patient's subjective report without considering the objective performance metric overlooks valuable data. While patient comfort is important, objective measurements provide crucial information about physiological function. Ignoring objective data can lead to misdiagnosis or a failure to identify underlying issues. Immediately escalating to the optometrist without any initial paraoptometric assessment or consideration of potential causes is inefficient and may not be necessary. The CPO scope of practice includes initial assessment and data gathering. This approach bypasses the paraoptometric's role in preliminary evaluation and data interpretation. Professional reasoning. Professionals should adopt a systematic approach when presented with performance data. First, review the data for any significant deviations or trends, even if within a broad acceptable range. Second, correlate objective findings with the patient's subjective report and history. Third, consider potential physiological explanations for the observed data. Fourth, based on this comprehensive assessment, determine the appropriate next steps, which may include further testing, observation, or consultation with the supervising optometrist. This process ensures that patient care is data-driven, patient-centered, and aligned with professional responsibilities. Question 19. The review process indicates a paraoptometric has documented the prescription of base-out prism for a patient complaining of blurry vision at distance, without a corresponding diagnosis of a binocular vision anomaly. Which of the following represents the most appropriate understanding of prism's role in vision correction according to the Certified Paraoptometric (CPO) regulatory framework? Option A. Prism can be used to improve overall visual clarity and compensate for minor refractive errors when a patient reports subjective blur. Option B. Prism is a therapeutic tool used to alleviate symptoms of binocular vision dysfunction by optically shifting images and is prescribed in conjunction with, not as a substitute for, accurate refractive correction. Option C. Prism is an effective method for enhancing the focusing power of the eye to achieve sharper distance vision. Option D. Prism should be prescribed whenever a patient reports discomfort or strain, regardless of specific binocular vision testing results. The correct answer is B. Prism is a therapeutic tool used to alleviate symptoms of binocular vision dysfunction by optically shifting images and is prescribed in conjunction with, not as a substitute for, accurate refractive correction. Explanation. The review process indicates a need to evaluate the paraoptometric's understanding of prism application in vision correction, specifically concerning the appropriate use of prism for symptomatic relief versus refractive correction. This scenario is professionally challenging because it requires the paraoptometric to differentiate between the therapeutic application of prism for binocular vision anomalies and its potential misuse as a substitute for accurate refractive correction. Misapplication can lead to patient discomfort, inaccurate vision, and a failure to address the underlying refractive error, potentially delaying proper management. The correct approach involves recognizing that prism is primarily prescribed to alleviate symptoms associated with binocular vision dysfunction, such as diplopia, asthenopia, or visual confusion, by redirecting the image to the fovea of the deviating eye. It is not intended to correct refractive errors like myopia, hyperopia, or astigmatism. A paraoptometric adhering to best practices would understand that prism is a tool for managing binocular vision issues and should be prescribed only when indicated by specific tests and patient symptoms, and in conjunction with, not as a replacement for, appropriate refractive correction. This aligns with the ethical obligation to provide patient-centered care and a practice within the scope of their certification, ensuring that interventions are evidence-based and directly address the diagnosed condition. An incorrect approach would be to consider prism as a means to sharpen vision or compensate for a poorly focused image due to an uncorrected refractive error. This misunderstands the fundamental optical principles of prism, which deviates light but does not converge or diverge it to change the focal point on the retina in the way spherical or cylindrical lenses do. Prescribing prism to address a refractive error would be a failure to accurately diagnose and manage the patient's visual needs, potentially leading to prolonged symptoms and a lack of improvement in visual acuity. Another incorrect approach would be to prescribe prism based solely on subjective patient complaints without objective testing to confirm a binocular vision anomaly. This bypasses the diagnostic process and could lead to unnecessary or inappropriate treatment. The professional reasoning process for similar situations should involve a systematic approach. First, thoroughly assess the patient's chief complaint and visual symptoms. Second, conduct a comprehensive eye examination, including accurate refraction and binocular vision testing. Third, interpret the findings in the context of established diagnostic criteria for binocular vision disorders and refractive errors. Fourth, determine if prism is indicated to address a diagnosed binocular vision anomaly, and if it is appropriate to use in conjunction with the refractive correction. Finally, clearly communicate the rationale for any prescribed prism to the supervising optometrist and the patient, ensuring understanding of its purpose and limitations. Question 20. The efficiency study reveals that a significant number of patients are experiencing prolonged visual field testing sessions due to repeated instructions and perceived confusion regarding the task. Considering the visual pathway, which of the following paraoptometric approaches best supports efficient and accurate data collection while respecting the patient's neurological processing of visual stimuli? Option A. The paraoptometric proceeds with the visual field test immediately upon patient seating, relying solely on the automated instructions of the visual field machine, and only intervenes if the patient explicitly states they do not understand. Option B. The paraoptometric focuses on increasing the speed of the visual field machine's presentation of targets, believing that a faster pace will reduce testing time and patient fatigue, even if it means some targets are presented very briefly. Option C. Before initiating the visual field test, the paraoptometric provides a brief, clear explanation of the test's purpose, emphasizing that the patient should respond only when they see a light, and then demonstrates a few target presentations with immediate feedback on correct responses, ensuring the patient understands the light stimulus and the required action before proceeding with the full test. Option D. The paraoptometric provides a lengthy, detailed explanation of the entire visual pathway, from the retina to the visual cortex, before starting the visual field test, assuming this comprehensive background will help the patient understand the importance of their responses. The correct answer is C. Before initiating the visual field test, the paraoptometric provides a brief, clear explanation of the test's purpose, emphasizing that the patient should respond only when they see a light, and then demonstrates a few target presentations with immediate feedback on correct responses, ensuring the patient understands the light stimulus and the required action before proceeding with the full test. Explanation. The efficiency study reveals a need to streamline patient flow during visual field testing, which directly involves understanding the visual pathway. A paraoptometric must accurately interpret patient responses and correlate them with the underlying neurological processes of vision. This scenario is professionally challenging because it requires not only technical proficiency in operating visual field equipment, but also a foundational understanding of how light information travels from the retina to the brain. Misinterpreting responses or failing to recognize potential neurological implications can lead to delayed or incorrect diagnoses, impacting patient care and potentially violating ethical standards of practice. The correct approach involves a paraoptometric meticulously documenting the patient's responses during the visual field test, noting any areas of reduced sensitivity or absent responses. This documentation should be cross-referenced with the patient's history and any other objective findings. The paraoptometric then accurately relays these findings to the supervising optometrist, highlighting any patterns that might suggest a deficit within the visual pathway, such as issues at the retinal layers, optic nerve, optic chiasm, or visual cortex. This aligns with the Certified Paraoptometric (CPO) scope of practice, which emphasizes assisting the optometrist in patient care and data collection. Ethical practice dictates accurate reporting and a commitment to patient well-being, ensuring that all findings are presented clearly and comprehensively to facilitate appropriate diagnostic and treatment decisions by the optometrist. An incorrect approach would be to dismiss subtle or unusual responses as equipment error or patient inattention without further investigation or reporting. This fails to acknowledge the potential for underlying pathology within the visual pathway, which could range from retinal disease to optic nerve compromise or even central nervous system issues affecting the optic chiasm or visual cortex. Such an oversight could lead to a misdiagnosis, directly contravening the paraoptometric's duty to assist in providing thorough patient care. Another incorrect approach would be to attempt to diagnose the cause of the visual field defect independently. The CPO role is to support the optometrist, not to usurp their diagnostic authority. Speculating on specific neurological conditions without the optometrist's direct supervision or confirmation exceeds the paraoptometric scope of practice and could lead to misinformation being conveyed to the patient or other healthcare providers. This breaches professional boundaries and ethical guidelines. A third incorrect approach would be to focus solely on the technical aspects of the visual field test, such as ensuring the machine is calibrated and the patient is positioned correctly, without paying close attention to the qualitative nature of the patient's responses and their potential implications for the visual pathway. While technical accuracy is crucial, it is the interpretation of the data in the context of visual physiology that provides clinical value. Failing to connect the test results to the underlying visual pathway demonstrates a lack of comprehensive understanding and can result in incomplete or misleading information being presented to the optometrist. The professional reasoning process for similar situations involves a systematic approach. First, ensure technical accuracy of the test. Second, meticulously observe and record all patient responses, noting any deviations from expected patterns. Third, consider the anatomical and physiological implications of these responses within the visual pathway. Fourth, communicate all findings clearly and concisely to the supervising optometrist, highlighting any areas of concern. Finally, defer diagnostic conclusions to the optometrist, adhering strictly to the paraoptometric's defined scope of practice.